This morning is October the 25th. We're having our TheraCHAT. Today, of course, as always, with a little bit of coffee in hand. Today is our special guest. We have Elaine Richer, who is the CEO, and we have Jacques Nir, who is the COO of MyCureAll. My name is Chris Bolton. I'm CEO of Theracann International, and I have Oswaldo Bello, who's the CIO of our OS2 network and technical group. So today's talk is MyCureAll and why it's best-in-class technology. MyCureAll is a very interesting application, and I'm happy to announce we have reached a licensing agreement with MyCureAll to be able to include it as a module to OS2, our One System, One Solution software, which, as you know, is circulating the globe and becoming country interoperable. But without spoiling it any further, I'd like Elaine and Jacques to talk a little bit about MyCureAll. How did it come to be? Why is that application so important and timely? And then Oswaldo and I would love to discuss where we see this going internationally. So please, let's hear from you.
Hey, well, hi, everybody. My name is Elaine Richer. I'm a pharmacist by profession. I've been a pharmacist for over 25 years, worked for a lot of different companies. When I was just starting out as a pharmacist, that's when OxyContin actually came out on the market. And looking back, no one ever realized how much havoc is going to cause our society and how many lives it's going to take. Of course, as we're filming this, a few days ago, Purdue Pharma agreed to plead guilty to criminal charges. They'll be paying $8 billion in fees. Hopefully, they'll be paying because you know, I'm sure bankruptcy is one of the things that they are considering, and the company will be dissolved. Mm-hmm. It's, you know, it's too little, too late, mm-hmm. but it's a good first step. And I think the most important step would be having cannabis as part of the medication-assisted treatment and harm reduction. And this is pretty much how, as a pharmacist, I came to the cannabis field or became interested in cannabis field, is because when I started reading about cannabis a few years ago and realized the complicated history of cannabis in this country, in the United States, and in the world for the past probably 90 years or so, I was horrified, because I like to look at statistics. I like to look at numbers, and looking at cannabis, nobody has ever died from utilizing cannabis. Nobody had ever gotten addicted to cannabis, but we know what, you know, scourge the opioid epidemic was. And we know that right now we have friends and loved ones that take a lot of different medication for a lot of conditions. And when they start one medication, the side effect kicks in, and now you need to add 2 or 3 other medications to counteract the side effect of it, where cannabis is the most natural treatment option out there. And as a pharmacist, it's very important to me to not cause harm, to help the patient, to do the best we can. And I think this is our duty, is to help our patients and to utilize the right protocols. And as you start looking at cannabis and you start looking at, you know, there are potential drug interactions, there are still side effects from the patient's condition. So you need to choose the right strain, the right cannabinoids for the specific patient, for their condition. We need to do the right thing for the patient. And that's where that science comes in. And that's kind of how MyCureAll was born, is to really help patients with proper protocols, to respect the plant and to give the patient the right choice.
Just want to add to that, because I think part of what got me so led onto this, and I think I mentioned this before, is when the COO, my wife, brought this whole project to me and talked about medicinal cannabis, my jaw almost dropped, right? Like, what an exciting adventure. I know a lot of people that have always used cannabis, never really identified as medicinal cannabis. But then I started hearing what she was saying and approaching this from a client-centered approach, a patient-centered approach, where we can get the assessments, where we can uproot people back into a system for an alternative sense of care, right? We talk about medication-assisted treatment, but also coming through and being able to deal with the stigma and start realizing that if it's a formal treatment with protocols and evidence behind how it's treating people based on those cannabinoid properties, then it's a science and it's a medication and it's not just a random plant used, right?
Right. And I'm going to have Oswaldo talk a little bit about how we like MyCureAll as an application and the way it collects and shares data. So I'm going to leave that for you to review. But from my point, having worked with international regulators at a federal, provincial, or state level, going on 8 years now, I'm still flabbergasted that these are often departments of health, and rarely, if ever, are the medical cannabis projects that they implement through regulation patient-centric. Rarely, if ever. What they've done is they've put in a very complex schema of how a producer, a processor, and distributor can get licensed to be able to provide a legal, what they call legal product to the market. But there's an absolute disconnect then between the producer, the prescriber, the doctor, for example, the pharmacist who then has to find the product to be able to fill that prescription. And of course, you have a patient who doesn't have even access to common marketing materials because that's obviously very heavily regulated in and of itself. And so you get a word of mouth engine that isn't all that useful when different people behave differently depending on the cannabinoid profile that you're talking about. And then, of course, we have fraud in the way that the label is going onto the product. And we just saw another case of this this weekend. Another Canadian company has been slapped with not putting proper data on the label. They went lab shopping to get what they want, not what it is. And so that's obviously created a lot of problems. And they're overcomable. Like, I mean, countries that we work in have found ways to be able to connect patients to doctors to pharmacists to licensed producers, but rarely, if ever, do they ever have a feedback loop between each other. And here we are in an industry that's less than 7 years old, trying to make a product that you don't know if it's actually benefiting directly the end user, except for medical study. And even then, the medical studies are few and far between. I can think of, and I'll turn this over to Oswaldo, but I can think of where we're working in other parts of the world right now, where they only limit it to one molecule, CBD. That's it. Mm-hmm. But they're not requiring the testing of what else went into the oil, other than it has to have, let's say, 0% THC, which is very unfortunate. But other cannabinoids are likely going to be added into the product. It's too expensive just to take them out. But they're not on the label, and the end user doesn't know, and there's no feedback loop to even see if the efficacy is worked well. So that's what that brought us on our journey through One System, One Solution software, OS2 team, which has been led by Oswaldo, to find an application that would help better educate, better match, and better collect data in a way that as you have on your background, HIPAA compliant, to meet an international privacy standard amongst all of this, right?
If I can add to that, Chris, what we've seen out in the market, working with the cultivators, the LPs, who at the end of the day, depending on the jurisdictions, will deliver this medicine directly to patients. But again, like Chris is saying, there's no, clean guidance on what should be produced and delivered. So they kind of end up having to do, I guess, a little bit of customer management on their own and kind of track how patients are feeling, not only for quality assurance purposes, but also to kind of have a better gauge of what's working, along the lines of illnesses. So it's very challenging for them to actually guide the patients. And then again, there's always the disconnect between the prescriber and the actual delivery of the medicine, which is also very interesting. Again, we're looking at an entire supply chain that should be all data driven, that should be all based on medical facts, and it doesn't happen regularly, right? So you end up having this disconnect.
Right, and it isn't over yet. What we're seeing now is other plant-based medicines are coming online faster than we ever imagined. In Canada, again, the rush to psilocybin when none of it's legal, but prescribing it already. means that the doctor has to have the prescription filled from the black market. We don't know where it came from. We don't know how it was cultivated, if it was grown in poop, whether it even had E. coli 0157 in it. We have no idea. And the traceability of any of it is zero. So here we go again, 7 years down the line, and for a doctor to prescribe something where he doesn't even know where it comes from is criminal, to be honest. And I'm surprised the Minister of Health, and I'll say that publicly, in Health Canada is not quite addressed that issue yet. But good to see that there are applications that can be used, that when these new medical products from plant-based come online, that we already built the infrastructure to be able to load that data and help those parties within that triangle operate properly. So let's yeah, sorry, Oz, and then back to Elaine and
yeah, just to finalize on what was our interest in MyCureAll, right? So we are engaged through the entire supply chain, and we see value in actually being able to at least propose, the ideal of better treatment to patients, because we are connected to through the entire supply chain to all of them. This will also help improve what our customers are actually currently cultivating and manufacturing in terms of product. So we see, it's a win-win all the way around.
Right.
I think one of the things that, Chris, you mentioned, we have the product, but we really don't have the right way of growing it, distributing it, getting the data out of it. So it seems that bureaucracy took care of itself and kind of just left. And that's it. And now it's up to you guys. You just figure out what works for you. And that's unfortunate. And that seems to be depending on which level, but it is something that we see as being, everywhere. Again, it's global. It's not just that it's US or Canada. And you see some individual territories or some individual states in the US that try to do the right thing. But again, because for us, it's not federally legal, so the buck kind of stops here. We know statistically that medical schools do not teach endocannabinoid systems. So if the physician doesn't know anything about cannabis, how exactly comfortable are they going to be to prescribe it or recommend it to the patient? How are they able to check for drug interactions with the medication that the patient is currently taking? There's a lot of things that have to be taken into account when adding cannabis to a complex drug regimen. And what we're doing is that we're providing that education to a physician. We're telling them, okay, if the patient has this condition and they have these symptoms, that this would be the best strain for them. We unfortunately also have to take into account what strains are available in that geographical area. So in the United States, we actually go and recommend only what's available in the state that the cannabis is medically legal, because there's no reason to recommend something that might work a lot better but not available there. Right. And you can't transport it across the state lines. So those are the things that you have to really take, take kind of like, with a grain of salt. We need to make sure that we are recommending the right products. But I think from doing what we're doing right now, and from what you guys are doing, we're preparing the market to do the right thing for the patient at the end of the day, because we have the best information from the clinical studies that are out there, as well as anecdotal information from the physicians, from the medical professionals, from the dispensaries and patients, to what worked best. And that's what's very important.
And you're also protecting that data. Of the many groups that we looked at, they gave lip service to the ability to ensure that that data met Canadian Privacy Act, US HIPAA, and then of course the extreme privacy regulations at the EU, and you're well along in satisfying all of those requirements, which was very helpful to us. The other side of it too is the insurance side of it. We'd love to hear your thoughts on this, but for those Canadians that are part of this will know that Canada, 7 years in, still has yet to provide a DIN, a drug identification number to cannabis. It's a medical product that's strictly regulated, but it's not a medical product that you can get easy insurance for, which is completely asinine. And I'm surprised that someone hasn't sued the government for that. It's the only drug in the system that doesn't have a DIN that we're aware of, for example. But you're prepared, and your system is actually quite well equipped to manage insurance. And for other federal governments that we're working with internationally, I wonder if you could share a little bit about your experience in that and share some of the functionality. Go ahead.
So we have the International Cannabis Code that we created. So it's an ICC for either International Drug Code or International Cannabis Code that we are able to assist with billing. So insurance is an intricate part of patient care, and that's why we need to take that into account. And what we're actually able to prove to an individual insurer that a patient that is, and let's take an MS patient that is using Copaxone, that the cost to the insurance company goes between $3,000 to $5,000 per month for that one patient. They're actually going to be saving when that patient switches to the correct cannabis strain, because they no longer need Copaxone. And again, I'm not going to say that cannabis takes care of everything 100%, but we do need pharmaceuticals. And I'm a pharmacist, so I'm going to say that first and foremost, we do need medication. However, it's been statistically proven when cannabis is introduced, or depending on which disease state, and we can use, let's say, pain. So for cancer patients, when cannabis is introduced, 40% of patients stop taking opioids completely. And then you have 30% of patients that are able to reduce their opioid intake. Mm-hmm. And remember, opioids come with their own side effects, where cannabis really doesn't. There's very, very few side effects that cannabis has. So that becomes very important. So it is less expensive to the healthcare system overall for a patient to be on cannabis. And that's where the first thing we came up with was those international cannabis codes.
So, I mean, just taking from there and building out a claim that actually shows a reduction in the client's symptoms related towards their condition. And what they've chosen is their three major symptoms. And they say, whatever the, sleeping, getting out of bed, energy, whatever, and which shows that reduction, right, for the insurance company. It builds a claim, and that claim is based on subjective data from the client as well as objective data, which shows how the rest of the population's been affected by the same strain for condition and same cannabinoid properties. So, and it displays that so that can go to the insurance company so they can see in their hand, wow, this really reduced their symptoms. Maybe that's going to make them much more functional as a person in society and on the job, and less of a burden for the insurance company long term.
From the licensed professional, because if you look at it from, we help the licensed professional to come up with a proper protocol, and then that licensed professional can actually help the patient and say, okay, well, this has reduced, so we can try to, tweak it here and there. We can look at the right quantity that's needed for a patient for a specific condition. So that's also a very big thing. You have this bona fide established relationship between physician and the patient, and especially in this crazy COVID pandemic world when, you can't get out to the doctor as often as you'd like, and you have a lot more Zoom calls and you have a lot more phone calls. That helps also with all that paperwork that the physician has to prove that they have. Right. And that's something that we're providing. And then for a dispensary, we're letting them know, listen, you're 40% of your patients, you're a medical dispensary, 40% of your patients have Crohn's. So you probably want to make sure that you're growing this particular strain for those patients.
Right. And
you have that in stock always versus something that you really don't sell. And that's another thing, because we always want to have, the best, the most potent strain and the healthiest, newest strain out there.
One more thing about even the bud tenders and people out there that are distributing or giving the client their medicinal cannabis. Some strains aren't always identified with the same cannabinoid properties, and they change over time, right? So the bud tender who's sitting there not medically trained might be like, well, what do I give you now? And so the recommender, right? And you can say to the recommender, hey, this is the property that worked for the client before. What do I have in stock that matches this? Right, so they can pull a strain that's almost identical and say, wow, man, this indica has the same cannabinoid properties as what you once used. Why don't you try this?
No, that's a brilliant strategy, and you know, working with some of the earliest licensed producers in the world, the master growers, as we used to call them then. Now we prefer to look for what we call a grow technician, someone that's very data driven. But the old master growers just grew what they liked, and it was, will work for me, will work for you, and we know that that's not always the case, and so getting it down to micro batch and be able to produce what the market wants today and tomorrow and a month from now, a quarter from now, is really what's going to help these LPs survive. And Elaine, you hit it on the head. Don't grow what they don't know, and don't grow what they don't want. Grow what they need and what will be able to fly off shelf. That's what keeps the LPs alive and keeps them growing, right? So Oz, with regards to that, I wonder if you could talk a little in our minutes remaining here, and then we'll do a roll up. How we are moving forward with integration of MyCureAll as a module, and what does that mean in terms of an LP then having a full harmony then set of data from seed, clone, and tissue all the way through to final consumption, destruction, recall.
Yeah, definitely, Chris. We're very happy. We're on our earlier stages of integration, and it's basically, we already in OS2, as you know, we drive the entire data for the LPs, meaning we also know who they're selling to in the case of Canada, where the LP delivers to the medical patient. So adding the powerful insights that MyCureAll can deliver via integration will expand the capabilities of OS2 into delivering even more and better information to the LP.
Well, also
so they can
being
drive
able to do Sprout, right? So Sprout being
Yes.
able to do small batch, 32 plants per habitat. If there's a micro market or a subset of patients that require a specific strain, as Elaine was alluding to, that requires a specific repeatable cannabinoid profile, as Jacques was talking about, then we can do that through Sprout. But the problem is the producer doesn't often know what the market needs until
Yes.
after they've produced it.
Yeah, and we've seen that trend, right? And we've seen that trend in Canada where craft growers are becoming more and more popular just because their strains become, they go, viral, right? Because they're good, because they're happy, and they're, and then again, we also have to compare in larger markets where we also have the recreational. So it even broadens the borders of where you want to deliver.
But it's a conceptual change from let's make a 1 million square foot greenhouse and grow one or two strains that nobody wants, and we overfilled our vault, and now we have to stop growing. We see that, and that many people that look at the stock prices for those companies don't fully understand the reason the vault's full is they grew something that nobody really wanted. But that's the way that they're geared to operate, as opposed to using technology that provides a micro grow that allows you to boutique your cultivation inventory, right? You can have more than 1 or 2 or 3 or 4 or 20 or 30 strains growing at different rates and have them come out repeatably. It's really the game changer in our industry. We call that version 4, cannabis version 4. So to roll up then, I'll start with Elaine and Jacques. Thank you so much for working with us on this. I think this is going to be the start, as they say, of a beautiful relationship. We're very interested in rolling this software through as a module to OS2 internationally. We will be looking to do this in multiple languages in short order as well. And then love to be able to do maybe a quarterly review on how well that's going out, lessons and advice for those out there in the world on some of what we've learned. But love to hear your roll up in the couple of minutes we have remaining, and then Oswaldo, back to you to sum up. Go ahead.
So I do have to agree with you. I think this is the beginning of a beautiful friendship. I think it's wonderful that we'll be able to help patients, and we'll be able to really broaden our operation to the global market, and to see and to learn from the global market. Because I do believe certain European countries are far ahead of US and Canada. And we are able to bring something that those countries don't have right now in their arsenal. We have our protocols. We have the studies that we've done. We have the algorithm to help the patient and providers to utilize the best product. and we can help prove to the healthcare system in whichever country you're in that it is less expensive and more beneficial for the patient to utilize cannabis versus whatever approved drug is that they've been using at, during this time.
Yes, exactly.
I'm very happy about this relationship, this dynamic developing between Theracann and MyCureAll. The fact that the market is caught up, that it should have some patient-centered approach, that protocols are important, that sense of understanding is medication. I can't wait for this to be accepted more on a government basis for medication-assisted treatment on a general format, whether it's post-traumatic stress, whether it's for the opiate epidemic, general anxiety disorder, but to have that sense of relationship and building this in a fruition, or to be more international. I love the concepts that we brought up, that this could, interact with the brown bars in Amsterdam and all these different thought patterns we've had and how it could evolve. So I really look forward to this relationship.
Likewise. Oswaldo.
Yeah, from my side, from the technical side, I'm very happy. I feel MyCureAll has done an excellent job preparing, a strong platform that is equally to our own OS2. So, powering up both of the applications will definitely provide a powerhouse to the end customer, and we'll be able to gain better market with better insights and better knowledge at the end of the day.
Exactly. So with that said, happy Sunday, everyone. Enjoy the fall. There's parts of Canada that are in snow already. I saw pictures of that this morning. Here in Panama, rainy season is never ending. But there's no snow. And then, of course, you're getting some chillier temperatures as well. So as our year progresses, I look forward to checking back in with you as to how well things are running, and we'll talk to you then. So thank you all.
Have a great Sunday.
Take
care.
Okay.